Hi, I'm Dr. Gulani at Gulani Vision Institute in Jacksonville, Florida, USA. I have worked with keratoconus patients from all over the world for over 3 decades. It's become my passion to help them see. And many a times I get questions not only from patients but even their caring eye doctors, optometrists, eye surgeons, and even in eye care industry where I teach all over the world. And I want to today go into the basics of keratoconus and explain everything that I do and why this has become such a passion for me to help patients see again. So keratoconus, simply put, and I'll draw it out for you. Here is your normal eyeball, and here is your cornea, which is the front part, clear part of your eyeball, like the viewfinder, if you may, transparent and what you see through. Normally, this cornea is dome-shaped, as you see. If you can see in this eye model right here, this is an eye model right there, and that's your cornea. It's dome-shaped. You see that? Meaning it's a perfect circle, pretty much shaped like a basketball in a perfect sphere. And these corneas can be worked on, and that's what we work on when we do LASIK surgery. My new techniques of no-cut LASIK, like laser plastique techniques, or PRK, epi-LASIK, SMILE, all those surgeries are done on top of this cornea, all right, to correct the shape. Keep that in mind as I'll come back to shape when I describe keratoconus. So when the normal cornea from a dome becomes a cone, you see that? It becomes a cone. This is now called keratoconus. Kerato meaning cornea, conus meaning like a cone. So you can imagine how distorted the vision is looking through this viewfinder, which is keratoconus. So imagine this cornea becoming like this. Obviously your vision is very distorted because you're looking through a very distorted cornea. So keratoconus, the way I like to define it, is don't get scared of the word keratoconus. Think about what affects it, and that's what I encourage eye doctors to understand. It's basically a cornea that has undergone extreme shape problems, become a cone from a dome. Additionally, it becomes thin in the center and the periphery, and in most cases even may have a scar on the cornea, all right, which affects your vision. So all these things impact your vision. Patients come with various complaints. They're seeing double, triple, halos, glare, starburst. Vision is just not right. It's blurry despite glasses and contacts and keeps on changing. These are the most common complaints, including night vision issues and reading issues in patients. So that's how keratoconus patients present. Many patients have been referred to me for, they just went to some LASIK place for LASIK, and then they got diagnosed with keratoconus, and now they're told nothing can be done. So if you have keratoconus, either if you know it or don't, this is what keratoconus is, and it can be helped. All right? So now that you understand keratoconus, let's summarize for you. The normal shape of the cornea is a dome, perfect dome. When that becomes a cone, and this is quite often genetically driven, nothing you did wrong. Now there are studies that are also adding to our already known clinical knowledge that rubbing the eye worsens it. Also, there are other factors that affect this cornea. Very commonly, they are also associated with allergies. These patients have a lot of allergy called atopy, and that's why they also rub their eyes. They also rub the eye to stimulate vision because they are that blinded in their vision, right? So they may have these associated symptoms. Also, don't forget, in my experience having seen these patients, some patients actually have other medical conditions that go with it, like they may be extremely tall from Marfan syndrome, they may have Ehlers-Danlos syndrome, they may have other collagen vascular problems, they may have associated diseases, they may also have dry eyes because the tears cannot climb up to this cone, so it dries up the eye. So many associated things that can be there in the body presenting as keratoconus, or keratoconus could be an incidental finding in the medical condition that the patient has. So we must always look for all that before we plan a custom design treatment. That also brings me to a point that I love to share with all of you, is never accept cookie cutter work. Make sure it's designed to your eyes, all right? So we understand what keratoconus is. Cornea that is thinner than normal, can be scarred, very high regular astigmatism, cone shaped so glasses cannot work, your vision is completely distorted. Now how do we help these patients see? So my whole philosophy for keratoconus is very simple. I believe that all these patients can see. Let me repeat that. I believe that all keratoconus patients can see, and with that attitude, of course keeping safety and ethics in mind, I proceed. And I break down keratoconus surgeries and treatments that I've been doing now for over 3 decades, over 20 different techniques unlimited technologies. I've broken them into two simple categories: structural surgeries, visual surgeries. Visual surgery is when a keratoconus patient can actually see through glasses. All right? If they can see through glasses, whatever their refractive error be, they may be nearsighted, farsighted, and astigmatism, but they're seeing well with glasses, usually more than 20/40 vision. I call them visual, meaning they have visual capacity despite the keratoconus. Now, if they are those patients that cannot see without glasses and need a contact lens to see, like a hard contact lens or a scleral contact lens, those are structural cases. Because, understand this very well, a hard contact lens or a scleral contact lens works like a Superman suit. That's how I describe it. So when you put it on, you have a perfect six-pack in the front. But when you take it off at night, you have a 40-inch waist. All right? Which means you're basically hiding the problem, not treating it. So a hard contact lens or a scleral contact lens can be used for keratoconus patients. They do make them see, but that is not correcting your underlying problem. Think of this as having maybe a fractured bone, right, in your leg. Instead of fixing it, if I just give you a crutch and walk, yes, you can walk, but that bone has not been fixed. It'll keep on deteriorating and getting worse until you come to me with even worse problems, that now it is scarred, it is improperly aligned, and now you need some kind of transplant, which we want to avoid. Transplant is not a bad thing, but a corneal transplant doesn't give you vision without glasses in most cases. In fact, there is a high chance of rejection. Lifelong, you have to be careful of any trauma, and the vision is not that great. Unaided, we call it, or without glasses and contacts. So, and it's an interventional surgery, right? In future, you'll have cataracts, glaucoma, all that kind of stuff. So you want to avoid a transplant or keep it as the last resort. All right. So how do I approach keratoconus? As I told you very simply, I divide all my treatments into structural category and visual category. Visual are those who can see with glasses, not contacts. With glasses, more than 20/40 vision through that eye, no matter what the level of the keratoconus is. If they are visual, I go with visual surgeries. Depending on the thickness of the cornea, depending on your stability, I would like to do laser plastic surgery, which is I use a laser to shape this keratoconus cornea into a nice dome, which is a normal cornea. We remove very little amount of tissue because I'm not cutting like LASIK. I'm not using any blades or anything to make any flap. There is no flaps. Using few microns from your cornea, I shape the cornea. And remember I taught you, vision is all about shape. I bring you back to a dome-shaped cornea despite your keratoconus, and you're back to vision without glasses, contacts in most cases. Now, if laser plastic, it cannot be applied because your cornea has become too thin, and yet you are very nearsighted. Remember, you're still visual category, meaning you can see. If you're very nearsighted and I cannot do laser plastic because your cornea is too thin or you're too nearsighted beyond the range, then I put in an ICL in the eye. It's a contact lens that I put on top of your natural lens. So that ICL that I use is actually, it's called the internal contact lens, if you may, to simplify it. It's a contact lens-like device we put inside the eye with numbing drops. It's just tucked away. You cannot see it. You cannot feel it. There's no pain while it's there. And you put it on top of your natural lens inside the eye. Surgery takes a couple minutes with numbing drops, and you're back to vision without glasses or contacts. So you see, while it's visual, you can use all these visual surgeries that I do anyways in patients who come, normal patients who come with glasses and contacts. And that's how I tackle it. Now, if in this case, you have vision categories, we're going further down now from ICL. Let's say you're a keratoconus patient, but you're over 60 years of age and you have early cataract. Now, again, I'll take your cataract out. This cataract, I will take it out and I will put a new dimension, next generation, premium lens technology that can make you see, and I place it in place of your cataract. That is very similar to what we do cataract surgery in normal eyes, but the way we do it with all our advanced techniques and optical concept, this is called lensoplastic surgery. Again, with numbing drops, no stitches, you are done. And forever, because the cataract's gone. So these are just basic visual techniques. We did laser plastic, we talked about ICL, we talked about cataract surgery, and also among all these refractive surgeries, you can even combine them. Remember, you can even combine. There's no restriction to that. So you can stage it. Let's say somebody with keratoconus is in the cataract age. I may do the cataract surgery first and then come back 3 months later and do laser plastic to shape the cornea to match the optics, and you're back to excellent vision. Similarly, I can put the ICL and laser plastic later. Or I can do laser plastic first, remove the scar on the keratoconus, and then go inside the eye to do ICL or cataract depending on the category. Are we clear, guys? So these are visual techniques that can be done in these patients to bring them straight to vision and actually give them freedom despite having a keratoconus. Now, the role of cross-linking is very important to me. Cross-linking is very important, but it should not be randomly done on people. After you have done visual surgeries on patients, then you can lock it in by cross-linking this cornea forever, and you are done. Now, cross-linking is a process where you take your normal cornea, which is thin. Think of this as a normal, very flail cellophane paper. If I make it firm like plastic, now this is how cross-linking works. It firms up the keratoconus cornea by a process where we use a special dye, which is a vitamin actually, B2, and then we use a special ultraviolet light mode on that with a protocol, and that firms up your keratoconus cornea. Remember, your keratoconus cornea was a thin cornea, very weak, it moves, all that becomes stable. But the reason I like that to be done after the visual surgery is once you've got the vision out of these eyes, stabilize it with cross-linking. I do not like people being cross-linked first and then being left like that without vision. Some cases we may want to cross-link first. If you're moving a lot, meaning your measurements are moving a lot, then you want to lock it in first and then fix the vision. All right? So very important aspect of cross-linking, please. Now, even these revision corrective surgeries can, like I said, be used singly, just summarizing for you, or can be staged or combined to bring you to the most excellent vision outcomes I humanly can to help you, leaving a nice and safe eye in place. Now, in case you are not visual and you're structural meaning you are a patient who cannot see through glasses. You do need a hard contact or a scleral contact to see, and you cannot be refracted, remember, through the lenses. So now you are structural. Now my main aim becomes to correct your structure or foundation. To do that, what I'll do here is I'll just draw on the side so you can keep understanding while looking at the anatomy, is I create in your cornea, which could be a cone, right? For example, let's just draw over here for our semantics. This is your cornea. I create channels in this cornea with a laser, channels, and I put like braces, rings into the cornea, and that looks like something like this. That being your cornea, the braces look like this. This could be intact rings, Ferrara rings, Kera ring, anything available in any country. With my international privileges, I've used most of them. Here, mostly I use the intact rings in my unique corneoplastic mode, different depth, different sizes. I pair them differently to change the shape of the cornea. So think about it, I put braces into your cornea. If your keratoconus is a spine and it's crooked, I have just put 2 rods on each side to straighten it. Structural surgery without doing a transplant, correct? Now, this structural surgery, if this patient becomes visual category from structural, that's an amazing outcome we see in a lot of our patients. Now, once he's visual, again, I can do laser, I can do ICL, I can do lens-based surgery or combinations. You see that? Now, let's say they have gone beyond the intact concept. The cornea not only is a keratoconus, but it's also, I'll just draw it inside here for you, is also scarred and become very thin and less than 200 micron. Now you cannot put ring channels inside because you'll still have a scar you can't see. This is where I do my lamellar graft technique. I hand lamellar, I try and dissect off. If you're looking at a cornea with a scar, let's say over here, if this was the scar, I remove just the top layer of the cornea and throw it away. And then I put a donor cornea on top. So we haven't done a full transplant. We removed the scar and we gave it more strength, right? And 6 months later, again, I can do laser, ICL, lens, any combination to make that patient see. So these are structural surgery. Again here, cross-linking comes in. After you have done the surgery and turned them visual, you can permanize the outcome with cross-linking. You see how all that works? And here's the best part. All these structural surgeries can still work with the visual surgery, but they decide where you start based on your vision, right? So to me, it doesn't matter. Whenever I get referred these keratoconus patients from all over the world, I keep asking for, give me the glasses number. That's why my entire brain starts thinking into these categories. I'll now take all this away so it doesn't confuse you, and I'll summarize for you over here. So my way of thinking is structural and visual. Visual, I can do laser plastic, I can do ICL, I can do lens-based surgery in the eye, or combinations. Structural, I can do intact surgery in the eye, lamellar graft, I can do cross-linking on these patients, and all of these surgeries of structural, there is a chance that this patient can become visual. That's why I don't want patients of keratoconus to wait for so long. I want them to come in as soon as possible while they are visual, so we can get them to vision, and in most cases without glasses or contact lenses. When they come to me structural, it becomes an additional issue, because now we're doing structural surgery, see how they land, and they may now need a visual surgery if they become visual, or they can go into, at that point, scleral contact lenses or something with their optometrist and start seeing. So either way, if we are doing structural and they're still not become visual, you still help the patient because you at least arrested or stopped the keratoconus from getting worse. At the same time, you fixed the issue, you made it a better shape, correct? So this is very important. By not fixing it and just wearing a contact, you're not treating the problem, you're just covering it, you're hiding it. So here also very important to discuss the role of your optometrist is very important too, because they may need to fit you with contact lenses after surgery for getting the residual vision if you're not turned visual. But I want every eye surgeon to understand that keratoconus can be helped. So it doesn't matter how bad your cone is. It doesn't matter how scarred it is. It doesn't matter how blinded you are. You can be helped. Now, another important topic. Let's say you have had cross-linking, or you have had let's say some surgery in the eye, like a transplant, which I don't want in keratoconus, and now you come to me. You can still be helped. Remember, again, see how my mind is so clear. Doesn't matter what surgery you have, I still want to know, are you structural? Are you visual? This is all based on your glasses number, not contact lenses, your glasses. And that helps me decide which direction I'm going. Once I get my direction, I have no limits to picking technologies to make you see, or structural, and if I can turn you from structural to visual, that's awesome. Makes me very happy, because that means I can make you see, and in most cases without glasses and contacts, correct? So you understood this very well. We explained to you what is keratoconus, how I look at keratoconus. I don't want you to be scared of the diagnosis. Fine, it happened to you, not your fault. How to fix it, how to be careful, how to understand what to do, to be coming in earlier rather than later, not to jump into contacts and glasses as the only resort. Most patients are given resorts of cross-linking. Cross-linking is not a treatment. It's a way of stopping the progression of the cone. But like I always say, if you have a bent spine, let me explain this very clearly to you all. Cross-linking concept of mine, when I teach, it's called the Gulani keratoscoliosis concept. Keratoscoliosis meaning, if you look at our spine, right, let's just give it a curvature, okay? This is the human spine, let's say. In the spine, if it is crooked, let's call this a crooked area, all right? Now, just putting cement on the crooked area and saying it won't bend anymore, to me that does not make sense. Now you put cement on it, but you disable the patient forever, because now forever that crooked spine will stay crooked. Yes, you're making sure it doesn't bend anymore, but it's crooked forever. Why won't you first straighten this spine? And straighten it with, you'll understand, structural surgery. Intacts, lamellar, whatever you can, whether it's visual, make it straight. Now, put the cement on it, which is cross-linking. You see the concept? This is where cross-linking makes a lot of sense to me. Cannot just cross-link and throw them into a contact lens and now nobody fixed anything. In fact, you're permanently in that crooked shape of keratoconus for life. So that's what I don't agree with, and I believe every keratoconus patient deserves a chance to see. So no matter how bad your cone is. Summarizing for you, we define keratoconus. It's simply put a cornea that is just excessively D-shaped, distorted, thinned out, scarred in some cases, affects your vision. You don't have to just get cross-linked and fall into contacts and then wait for a transplant. No, you can be helped. Very important is decide, or have your doctor decide, are you falling into the structural or visual category? Then aim for vision the best you can. And in the end, even if you have to have residual contact lenses, no harm with it. Transplant should not be done unless it's the last resort for the reasons I just explained. And even if you had a transplant, you can still be helped because I can do visual surgeries on a transplant. No, that's possible. So keratoconus is a disease, is a condition, is a pathology, is an anatomical, an optical issue. But I want every doctor to understand these concepts and take this straight to vision and help thousands, millions of patients all over the world. So with any questions, guys, I'm always here for you. Dr. Gulani, you can email us, gulanivision@gulani.com. We're headquartered here in Jacksonville, Florida in USA. We have our YouTube channel. My amazing staff visiting doctors keep posting videos of our everyday patients showing transparent surgeries, patient reactions for you. It's all to inspire my colleagues and encourage patients not to give up. So if you have keratoconus, don't worry. You can be helped. For you, Dr. Gulani.